Namaste and good evening, everyone. A warm welcome to Onco Connect Live, a multi-cancer eSummit. We are honored to have you join us for today's event. We look forward to insightful discussion and meaningful discussion over next 2 days. With immense pleasure, I would like to invite Dr. Sachin Jain. He is a program convener and consultant medical oncologist at Ayush Gynae and Cancer Clinic and professor at PMIS Medical College for welcome and introduction note. It's over to you, sir. Hello.
Hello.
Sir, you are not audible.
Connectivity is not good.
Hello. Hello, Dr. Sachin Jain, sir.
The connected can you
So please start.
Yeah, can you hear? Yeah. Can I share my screen? Hello.
Yes, sir.
Yeah, can I share my screen?
Hi, Dr. Sachin. Are you there, Sachin? Yeah,
Good
very good
evening,
evening. How are you?
Sir, good evening, sir.
All set?
Yes, sir. Fine, sir. Good to see you, sir.
Thank you.
All set, sir.
Thank you. Good. So we are waiting for
Yes,
others
sir.
to join.
Sir, we are starting, sir. Now plan to start, sir.
Okay. Great.
Okay, sir. So,
please make it full screen.
yeah, can you see my screen? I have shared my screen. So, is it visible to you?
Yes, it is visible and you are audible. Please go ahead.
Yeah, thank you, sir. Thank you, everyone. I am Dr. Sachin Jain and working in Udaipur at PIMS Umada Hospital, along with the Ayush Onco and Gynae Clinic and associated with Paras Group of Hospitals. And I welcome you all for today's webinar. That is the Onco Connect Live.
Dr. Sachin,
Sir.
listen. It looks that you are logged in from two devices. Your voice is getting echoed.
Okay, sir.
तो यदि दो से किया तो एक को बंद करो ना, एक कमरे में दो डिवाइस है तो भी गड़बड़ होगा ये.
So now is it okay, sir?
Yes, it is better now.
Okay, sir.
Yeah.
So thank you, sir, and I welcome you all for today's webinar. That is the Onco Connect Live. As Nishan said, it is a 2 days webinar, and on day one today we will discuss about the updates in the breast cancer and ovarian cancer. For today's webinar, we have very fantastic and renowned speakers with us, like Dr. Mohan Sharma sir, Dr. Naresh Somani sir, Dr. Divesh Goyal, and Dr. Neha. And we have a number of panelists. We will discuss with them today's topics. So, without further delay, I want to start the topic today, which was given to me. That is the ASCO breast cancer updates in 2025. In this, we will discuss about the three topics today, like for the hormone receptor positive breast cancer, one about the triple negative breast cancer, and one about the HER2 positive breast cancer. So, in the first topic, that is the Chemi-G-strand plus CDK4/6 inhibitor for the treatment of emergent ESR1 mutations during the first line endocrine-based therapy and ahead of disease progression in patients with hormone receptor positive and HER2 negative advanced breast cancer. This is a phase 3 double-blind circulating tumor DNA guided, that is a Serena 6 trial. So, in this Serena 6 trial, the key takeaways are switching aromatase inhibitor to chemigistrant with the continuation of the CDK4/6 inhibitor, guided by the emergence of ESR1 mutation during the first line therapy ahead of disease progression. And it significantly improved PFS in patients with hormone positive receptor positive advanced breast cancer. So Serena 6 is the first global registrational phase 3 study to demonstrate the clinical utility of ctDNA and monitoring to detect and treat emerging resistance in breast cancer. The findings from Serena 6 have the potential to become a new treatment strategy in first line to optimize outcomes. Sorry. So in the background, approximately 70% of the breast cancer are ER positive and NATO negative. In our clinical practice, we see these patients. So estrogen receptor is encoded by the ESR1 gene, that is the hotspot ESR1 mutation, and lead to constitutive activation of the estrogen receptor and leads to the cell proliferation. And these mutations are generally rare, that is less than 5% at the time of diagnosis in the advanced breast cancer. But as we treat these patients with the AI and CDK4/6, then this mutation gradually progressed up in the 40%. We can found these mutations. So camizestrant is the next generation oral SERD and complete estrogen receptor antagonist and was designed to inhibit and degrade mutant as well as wild type of estrogen receptor. So ESR1 mutation can be detected in the ctDNA liquid biopsies prior to the progression of AI with CDK4/6, and in the open label PADA1 trial, switching to fulvestrant plus palbociclib upon detection of the ESR1 mutation ahead of disease progression significantly improved PFS versus continuing AI with palbociclib. In the Serena 2 study, camizestrant significantly improved PFS versus fulvestrant in pre-treated ER positive ABC, including in patients with ESR mutation. So Serena 6 tested the hypothesis that using camizestrant to treat emerging ESRM ahead of disease progression could extend the duration of benefit of first-line therapy. So in this, the ESR1 mutation surveillance done during the first-line AI plus CDK4/6, the patient must be on AI plus CDK4/6 more than 6 months or equal to 6 months. Equal to that, they have included 3 to 5, 6 patients, and after that, mutated patients are detected in the 548 patients, and finally, the 315 patients were randomized for this medicine. So this Serena 6 study is phase 3 randomized double-blind and placebo-controlled study. The male and female both patients with advanced breast cancer and estrogen receptor positive patients were taken, and all patients that have received AI plus CDK4/6 as initial endocrine-based therapy for ABC for at least 6 months they have included, and the mutation was detected with the ctDNA with no evidence of disease progression. So camizestrant was used 75 milligram, and another arm is the continuing AI plus CDK4/6. The primary endpoint was PFS, and secondary endpoints were PFS2, OS, and safety profiles. So this is the statistical design of the Serena 6 trial, and the baseline characteristics were similar in the both the arm, that is the camizestrant arm versus the AI arm, and the primary endpoint, that is the investigator assessed PFS. We can see that the median PFS is 16 months in the camizestrant arm as compared to 9.2 months in the aromatase inhibitor arm. The investigator assessed PFS by group. We can see in this forest plot also that the camizestrant is doing better in all the conditions, like with the age, with the region, with the menopausal state, as compared to the aromatase inhibitor with CDK4/6. The time to deterioration in global health status quality of life, also we can see the median time to progression or deterioration was 23 months in the camizestrant arm as compared to the only 6.4 months in the AI arm. The second progression-free survival is also better in the camizestrant arm, that is the at 12 months, 85.4% patients are still in the PFS2 as compared to only 74.4% in the AI arm. In the safety summary, you can see the adverse effects are almost similar in both the arms, and there is no new guidelines for the safety profile in this patient. And adverse event, the most common adverse effect is the neutropenia, and others are the anemia, leukopenia. The photopsia is a side effect of the chemical which is very less common, or we can say not found in the AI arm. And this photopsia is for the trial did not impact daily activities. So in the conclusion of this Serena 6, the switching AI to chemical with the continuation of the CDK4/6 inhibitor, guided by the emergence of ESR1 mutation during the first line therapy ahead of disease progression, significantly improved PFS in patients with hormonal receptor positive advanced breast cancer. The PFS benefit was consistent across the CDK4/6 inhibitor and clinically relevant subgroups. This chemical plus CDK4/6 delayed time to deterioration in quality of life versus continuing AI, and as well as also it is well tolerated and very low rate of treatment discontinuation due to adverse effects. The Serena 6 is the first global registration phase 3 study to demonstrate the clinical utility of ctDNA monitoring to detect and treat emerging resistance in the breast cancer. So the findings from Serena 6 have the potential to become a new treatment strategy in oncology to optimize first-line patients' outcome even prior to the progression. So the second, the study published in the ESCO 2025 is related to the triple negative breast cancer. They have studied the sacituzumab govitecan plus pembrolizumab versus chemotherapy plus pembrolizumab in patients with previously untreated PD-L1 positive, advanced or metastatic triple negative breast cancer. Primary results from the randomized phase 3 ASCENT-04 keynote D19 study. So the key takeaway, ASCENT-04 and keynote D19 phase 3 study, there is an unmet need for better treatment in the first line setting for the patient with PD-L1 positive metastatic triple negative breast cancer. SG plus pembro led to a statistically significant and clinically meaningful improvement in PFS versus chemo plus pembro, and these results support SG plus pembro as a potential new first line standard of care. So the remaining unmet needs are the median PFS observed in prior studies of chemotherapy in combination with immune checkpoint inhibitor was 7.5 months to 9.7 months, and most patients still experience disease progression. And about half of the patients treated with first line metastatic triple negative breast cancer do not receive second line treatment. So SZ is the only TROP2 directed ADC with demonstrated overall survival benefit in multiple phase 3 studies. It is approved second line in metastatic TNBC and pre-treated hormone receptor positive and HER2 negative MBC in multiple countries. So early studies have observed improved anti-tumor effect when immunotherapy is combined with ADCs. So in this study, they have taken PD-L1 positive patients to more than 6 months since treatment in the curative setting, and they have from the SG plus pembro versus chemo plus pembro 2 arm were there, and endpoint was PFS by BICR, overall survival, and overall response rate and safety profile. This is the statistical analysis of this study, and the demographic and baseline characteristics are similar in the both arms, like patients in the number, in the median age, as per the race or ethnic group, geographic region, eco performance status, curative treatment, free interval, the PD-L1 scoring, the metastatic sites, the chemo selected prior to the randomization, and any prior anti-PD-L1 therapy. So we can see in this graph that PFS by BICR is better in the SGR, that is the 6-month PFS rate is 72% as compared to the chemotherapy arm, which is the 63% only, and 12 month it is 48% versus 33%. And PFS by investigator assessment is also better in this arm, that the 6-month PFS is 75% as compared to chemotherapy, that is 61%, and 12-month PFS is also better in the SGR. So PFS by investigator assessment was consistent with the BICR analysis and demonstrating PFS benefit with SG plus pembro versus chemo plus pembro. This is the subgroup analysis of the PFS by BICR, and we can see this correspond also showing that the SG arm is better as compared to the chemotherapy arm. The overall survival at primary analysis also the data is still immature, but 26% it is the mature rate, and however a positive trend in improvement was observed for the SGR along with the pembro. The tumor response and duration of response by BACR is also better in the SGR, that is the 16.5 months as compared to the 9.2 months in the chemotherapy plus pembro arm. The exposure and safety summary is also showing that is the grade 3 were similar. The side effects are similar to both the groups, and the dose reduction or treatment discontinuation were lower with the SG plus pembro as compared to the chemo plus pembro. And the most common adverse events, like more than 20% in any group, are the neutropenia, fatigue, nausea, diarrhea, anemia, and these are almost similar in the both groups, but it favors the SG plus pembro as compared to the chemotherapy arm. And the adverse effect related to the special interest are like those side effects related to SG are the neutropenia, hypersensitivity, severe infection secondary to neutropenia are slightly higher in the SG arm as compared to the chemotherapy arm, and related to the pembro side effects are almost similar in both the arm or are less in the SG arm. So in the conclusion of this trial, the ASCENT 4 or Keynote D19 is the first randomized phase 3 study to evaluate the efficacy and safety of an ADC checkpoint inhibitor in combination for first-line treatment for the patient with PD-L1 positive metastatic triple negative breast cancer. The SG plus pembro led to a statistically significant and clinically meaningful improvement in the PFS versus chemo plus pembro. The PFS benefit was observed across the pre-specified subgroups. OS data are immature but are early trend improvement was observed. The overall response rate was higher and responses were more durable with the SGR, and the safety profile of SG plus pembro were consistent with the established profile of either agent, and no additive toxicity was observed. So in the result, this study supports the use of SG plus pembro as a potential new standard of care for patients with previously untreated PD-L1 positive, locally advanced, unresectable, or metastatic triple negative breast cancer. So this is a new treatment line for the triple negative breast cancer as per this ESCO 2025. And this is the third study. There is a TDXD plus pertuzumab versus Taxane plus pertuzumab plus trastuzumab for first-line treatment of patient with HER2 positive advanced and metastatic breast cancer. So this is also published in this ESCO 2025. And the key takeaways of this are the 44% reduction in risk of disease progression or death with TDXD plus pertuzumab versus the THP when we are using it as a first line. So TDXD plus we demonstrate a PFS improvement versus the established first line standard treatment like THP in HER2 positive advanced and metastatic breast cancer. The safety was consistent with non-profile of individuals treatment. So this TDXD plus pertuzumab demonstrated a statistically significant and clinically meaningful PFS benefit versus THP that was consistently observed across all the subgroups and may represent a new first-line standard of care for patients with HER2 positive advanced and metastatic breast cancer. So in the evolution of the TDXD, when we are using TDXD in the third line, then the PFS is 16.4 months. When we are using it earlier or prior to the second, like in the second line, then it is 28.8 months. And when we are using the first line, then PFS is still not reached as per these ESCO guidelines. So this is the rationale for combining the pertuzumab with TDXD. Pertuzumab is inhibiting the heterodimerization and TDXD inhibiting the homodimerization of the HER2 receptor, and ultimately they inhibit the PI3K acutine mTOR pathway, and lastly inhibit the cell proliferation and their survival. So this is the Destiny Breast 09 study design, and eligibility criteria was HER2 positive, advanced or metastatic breast cancer. Patient should be asymptomatic or inactive brain mets are allowed. D5 more than 6 months, one prior line of ATO for MBC permitted, and no other prior systemic treatment were recommended. They taken 3 arms like TDXD plus placebo, TDXD pertuzumab and THP, and we will discuss in this trial the THP versus TDXD plus pertuzumab arm. This is the statistical analysis. And this is the patient disposition, which is the similar in the both the arm. And this is the demographic and baseline characteristics. And these are the prior therapy taken with the both the arms. We can see that PFS by BICR is the primary endpoint when we are using TDHD plus per 2. Then median PFS in month it is 40.7 months as compared to the 26 months in the THPR. By the investigator assessment also favors the median PFS is better in the TDHD plus per 2 arm, that is the 40.7 months as compared to the 20 months in the THPR. This is the subgroup analysis which favors the TDHD plus pertuzumab is better as compared to the THP. These are the oral response rate and the duration of response, which also favor the TDHD plus per 2 arm as compared to the THPR. And oral survival is also favoring towards the TDHD and per 2 arm. This is the PFS2 and post-trial treatment. These are also favor that the clinical meaningful improvement with the TDHD and pertuzumab arm. Oral safety profile is almost similar, and there is no extra uh, as only the pneumonitis, and this is more common with the TDHD arm as compared to the THP arm. So the pneumonitis, that is ILD and left ventricular dysfunction, are slightly more common with the TDHD plus pertuzumab arm. So in the conclusion, the TDHD plus pertuzumab demonstrated a statistically significant and clinically meaningful PFS benefit by BACR versus THP, which was consistently observed across all the groups. The median duration of response is more than 3 years with the TDHD and pertu arm. Early oral survival data suggests a positive trend towards the TDHD and pertuzumab arm. So this trial demonstrated a statistically significant and clinically meaningful PFS benefit versus THP and may represent a new first-line standard of care for patients with HER2 advanced and metastatic breast cancer. So nowadays TDHD is also available in India. So in near future, possibly we will treat our patient with the first line PDHD and pertuzumab treatment. So thank you very much. And over to Nishan.
Uh, Thank you, sir. Next session is panel discussion on the topic of reviewing the first line treatment landscape for HER2 positive and HER2 negative ABC. This session is sponsored by Novartis. I would like to invite moderator Dr. Lalit Mohan Sharma, sir, Senior Consultant, Medical Oncologist and Hematologist at Mahatma Gandhi Hospital, Jaipur. And the panelists are Dr. Hemant Reddy, sir, Dr. Rohit Swami, sir, and Dr. Sandeep Perwa, sir. It's over to you, sir.
Yeah, thank you so much. And thank you, Dr. Sachin, for this nice platform. Truly love, in fact, rather than physical meetings, this sounds much better, easy, comfortable. And I can see many faces. अब हेमंत को देखना तो बहुत मुश्किल हो जाता है हमारे लिए. So great. So thanks to Novartis also for supporting this activity, and we will be discussing about the HR positive advanced breast cancers and how we place the different CDK4/6 inhibitors. So can someone share my slides, or you want me to try? From the backend team, can someone share?
Yes, sir. Yes, sir. Please.
Yeah, thank you. So we'll be reviewing that how we place the different CDK4/6 inhibitors in HR positive HER2 advanced breast cancer. And next slide, please. Thankful to Novartis for supporting us and supporting the academics, including help in the slides also for this panel. Next slide, please. So we know about the complexities or first line management of HR positive. Is there some background noise? Can someone mute the unwanted? Yeah. So in fact, if you see the complexities or first line clinical decision making, we know about the goals. So let me start with Dr. Hemant. Hemant, what are your goals when you see the advanced breast cancer?
Yeah, definitely, if I see advanced breast cancer patients, I have to see the patient's general condition, performance status, his attitude about disease as well as life, and definitely I will see the survival and quality of life in that patient.
Right. Dr. Sandeep, you have some difference of opinion, or you also agree for the quantity as well as quality of life, both issues together?
Yes, sir. Quality of life, as long as chemotherapy-free interval is also important consideration while considering the treatment.
Right. Next slide, please. So we all are aware about the ISMO guidelines, and I can see Neha also. Neha, thank you for joining. You are free to give your inputs. In fact, the young people are much more energetic than us. So the ISMO guideline, we all know, where do we place the CDK4/6 inhibitor? So Dr. Rohit, where do you place the CDK4/6 inhibitor in clinical practice?
So in MBCs are in the first line only, along with the AI. If there is any contraindication for AI, then fulvestrant is also in first line setting. It's indicated for second.
So we all are like aware and we all are like learned for many years that where do we place the CDK4/6 inhibitor? Dr. Sandeep, how about the chemotherapy part? Where do you place the chemotherapy?
So, only in those patients where there is a impending visceral crisis, impending organ dysfunction, only in those cases. Otherwise, majority of these patients are a candidate for endocrine therapy.
Right. And Dr. Rohit, how do you select the endocrine, like the CDK4/6 inhibitor in clinical practice?
So basically, it depends on the comorbidities of the patient. If there is a cardiac comorbidities, then I will, or hepatic comorbidities, I will definitely like to avoid ribociclib. Similarly, elderly patient tolerate abemaciclib and ribociclib poorly. Pelvo is better choice for the elderly patients. And then definitely the clinical trials outcomes, like there is a survival benefit of with ribociclib, though in the meta-analysis survival benefit is there along with the abema and pelvo also, but phase 3 study which is showing survival benefit is with ribociclib alone. So fit patient definitely will go with ribociclib. Otherwise, there is no head-on comparison of all of these three CDK4/6 inhibitors. So we can use any one of them as per the comorbidities and fitness of patient.
So truly appreciate. In fact, that is very, very relevant scientific answer. Dr. Hemant, if somebody is BRCA positive, where do you place the BRCA directed therapy?
Yeah, see, first line I will use if hormone positive and HER negative CDK4 inhibitor. Then when patient progressed on this therapy, then I can consider in second.
Very good, very good. And how commonly the PIK3 directed therapies you are doing?
Yeah, see, pick three when usually I try to do NGS or all markers initially when patient I diagnose in metastatic setting, but now I am not seeing too much patient who are well there. So in second line, usually I will ask to do.
Great. Next slide, please. So this is the case capsule. 64-year-old postmenopausal, HR positive, HER2 negative, early breast cancer. She was treated with letrozole in the adjuvant setting. And then she, after 2 years, developed the metastatic disease. So, Dr. Rohit, how do you approach at this point? Next slide, please.
So this patient is metastatic hormone receptor positive and HER2 negative breast carcinoma, and it is endocrine sensitive disease also. So definitely I'll go ahead with since the treatment completion is 2 years after the adjuvant hormone therapy, then I can go with the AI plus CDK4/6 inhibitor. initially also. And I will also like to go ahead with the ESR1 testing because this patient has received already hormonal therapy. And ESR1 can be mutated in the patient who had previously received hormonal therapy. And as Hemant sir has said, if the baseline NGS can be done, we can go for PIK3CA and ESR1 and BRCA1, BRCA2 also. Then that will be very helpful for starting and choosing for the first line therapy. But definitely, most of these patients are going to end with the CDK4/6 inhibitor and AI in the first line.
Dr. Sandeep, you also do the whole panel at this point, or you wait for the further progression and then you do the ESR1 and other mutation?
ESR1 I will do only on the progression, and otherwise I will start straight away with the endocrine therapy along with the CDK4/6 inhibitors.
So any of the panelists, do you do a biopsy on each progression, or you feel that once HR positivity is there, then there is no point in doing repeated biopsy?
I think we have to do on each progression, but see, it's very difficult to get the biopsy or convince the patient. But at least we have to inform the patients, or we have to counsel the patient about the doing and uh, what is the significance of doing this second biopsy every time, so we can get the mutations in this progression, why patient is progressing. So it is, I think, helpful to select the therapy for us.
Right, very right. Next, please. So we have discussed about efficacy, safety, and quality of life. These are the major goals which we are there. So, Dr. Sandeep, out of the 3 available CDK4/6 inhibitor, what are views, like which one you find the most suitable with all these 3 goals?
So I have experienced a better safety and a better quality of life with the uses of ribociclib. It's relatively easy to handle. The toxicities are relatively mild in terms of uh, cardiac toxicity, ECG monitoring, hematological toxicities are relatively easy to handle, and the gut toxicity is also pretty less with the ribociclib. And efficacy wise, it is the only CDK4/6 inhibitor which has shown the overall survival benefit. So ribociclib is my first choice.
Yeah, Dr. Rohit, how about you? You have some difference, or?
No, agreed with Dr. Sandeep. Ribociclib is also my first choice CDK4/6 inhibitor because of robust available data of survival benefit, as well as the loose motion part of abemaciclib is quite worrisome in these patients. And in the Paloma, definitely because of loss to follow patients, there was no survival benefit. So ribociclib is my first choice of CDK4/6 inhibitor.
Dr. Hemant, in real life situation,
Yeah,
you
definitely ribociclib is good option, but see, most of the patients they can't afford. So nowadays, palbociclib we are getting Indian drugs very cheap. So usually, in my situation, I always counsel about ribociclib, but patient can afford only a palbociclib only. So in real practice, only I am means out of 10 patients, 8 patients they are taking only palbociclib.
Yeah, so in fact, given a choice, we all will have preference for ribociclib, but the practical scenario, real life situation might be different as compared to our own preference and choices and based on the evidence. Next slide, please. So these are inclusion criteria. So Dr. Rohit, do you find any difference in the Mona Lisa 2 and the Monarch 3?
So in Mona Lisa 2, there were few endocrine resistant diseases. Early relapses were there. But in the Monarch 3, all of these patients were primary endocrine sensitive. So this was the, so definitely in the endocrine sensitive patient, there is going to be robust effect of CDK4/6 inhibitor along with endocrine therapy. So these were the differences in this. Monarchs 2 as well as Paloma 2 had endocrine resistant 20 to 30% of patient, whereas Monarchs 3 all were primary endocrine sensitive.
I think that is very, very important that to us the trial design looks same, but there is a difference about the endocrine sensitive population. So almost quarter of patients, they are like high risk patient. Next, please. So this is what we were discussing, and all the CDK4/6 inhibitors in first line, they are preferred in post-menopause. Next, please. Next slide, please. So, coming back to Dr. Sandeep, PFS or OS?
Sir, in a chemo-responsive disease like breast carcinoma, PFS is a reasonable target. But when I have multiple lines of chemotherapy, targeted therapy available with me, the overall survival may be same in the two lines of therapy. So overall survival may be same in both the treatment arms. That I mean to say.
Dr. Rohit, you also agree that PFS and OS, they are like similar, or you have some other thought?
So, as Dr. Sandeep said, in the patients which are very much sensitive to the treatment, to the first line treatment, PFS can act as a surrogate marker for the survival benefit. So, if there is a significant PFS benefit, then we can opt that option. But if there is a presence in between the three options, if there is also robust data for survival benefit, also, I'll head toward that option.
Right.
I'll go toward that option.
Very good. Next slide, please. So, the CDK4/6 inhibitor from both ET sensitive, ET resistant population we have discussed. Next slide. This also we have discussed that the endocrine population sensitivity was different in both these monarch 3 and monalization. Next slide. This is important that in a patient with metastatic disease, how common is the OS benefit? So, Dr. Hemant, over to you for this discussion of OS data.
Yeah, definitely. In those disease who has a long post-progression survival, and many type of therapies are available. In that one, OS benefit, PFS and OS benefit is important. So I think this ribociclib is showing even in sensitive as well as resistant clone survival benefit compared to other two molecules or two trials. So I think ribociclib is a good drug in this situation.
Dr. Sandeep, if you see the OS data in the SABC S23 and the eSummit, it is more than 5 years. So, do you see such robust data in real life also?
I have not seen such a kind of overall survival in my clinical practice.
Rohit, you have seen some patients survive for 5 years plus?
I had seen one patient who is still surviving, still doing good after 4 years on ribociclib and letrozole in itself. But 2 to 3 years is very much common. Now I'll see in my practice furthermore whether the patient reaches 5 years or beyond the 5 years.
So, in fact, we have few patients who are like around 5 years or 5 years plus minus few months, and they are sailing absolutely well. And every time, like once a year, we do PET CT scan, and the patient and family keeps asking, "Sir, दवाई कब बंद करेंगे? अब तो रिपोर्ट नहीं आ रही."
That is, yes.
So that is always a like good point. But we wish that all patients should show such a dramatic response. Next slide, please. So ET resistance also we have seen that ET resistance is one important criteria. Next slide, please. So Dr. Hemant, when it comes to selection of CDK4/6 inhibitor, how do you select and what is your like most important point which affect the clinical decision?
Basically, it is a personalized oncology. We have to personalize the drug according to patient's need. So we have to balancing the efficacy, safety, as well as quality of life. So according to patient's comorbid conditions, cost, access, all things we have to see, and and we have to give the choice to patients the survival data as well as quality of life data to the patients. And if patient is affordable, no comorbidities, I think ribociclib is good drug. But if patient has some drug which is prolonging the QT interval, we have to see the other two molecules. So all things we have to see and select the drug according to patients. So I think no one drug, like if patient is fit but can't afford the drug, so things we have to choose according to patients.
I think very, very valid and very rational decision making that it's not one point answer. Dr. Sandeep, if ribociclib is you have selected, what dose you are giving, 600 or 400?
600 mg, sir.
Rohit, you
Daily.
also use 600 mg?
600 mg OD.
Yeah, in fact, there was one trial which somehow did not get popular, 400 milligram. But in fact, even if we reduce the dose from 600 to 400, probably we do not compromise in the efficacy. And the good point about ribociclib or Crexana is that there is a very robust patient assistance program. So in fact, the patients are sailing through well once they are enrolled in the patient assistance program. And I have like number of patients in two figure, they are getting excellent support for last more than 4 years. Next slide. So these are different trials. So Dr. Sandeep, which side effect bothers you too much in fact?
Hematological toxicity and gut toxicities, which I'm worrisome about these two toxicities.
I think this diarrhea remains major problem with the monarch and the amoeba. But again, with time, the patients do adjust to that. It's not like permanent.
I think after 3 months, patient will adjust.
Yes. Yeah. Right. Next slide, please. Next slide, please. So these are quality of life data. We all are aware of most of the things that the Mona Lisa or the ribociclib feels through relatively better as compared to the other, especially the diarrhea part remains major something. Next slide, please. So this also like we have discussed partly, but this looks very, very relevant to our Indian circumstances. So Dr. Rohit, in your clinical practice, do you give weightage to the ISMO MCBS scores?
Yeah, definitely, sir. So basically, uh, if there is a substantial clinical benefit, like there is a survival benefit uh, with a single drug as compared to other two options, then I will go with that only. So survival, as already discussed, if there is survival benefit with ribociclib in both post-menopausal peri and pre-menopausal patients, then ribociclib will be the first choice given to the patient also. But according to the affordability, if she wants to shift to Pelbo, then Pelbo is also option.
In fact, the MCBS score takes into account the cost as well as the efficacy of the drug. So in India also this accounts a lot that whatever price we are paying for one particular drug, what are the benefits? Maybe in terms of PFS, maybe in terms of OS, maybe in terms of maintaining the quality of life. So the Europeans are very, very cost like conscious oncologist, or the whole EU is like that. While on the American side,
Cost effective approach here.
yeah, so in American side, it is more of a not cost effective, but they go for more expensive treatment, maybe whatever benefit. So the ribociclib and the Crexana, it scores in fact 4 or 5 in many studies. We can see the first two Mona Lisa, two Mona Lisa 7, which were like in the postmenopausal as well as in the premenopausal. Both the MCBS score high. 4 to 5 is very good score. Next, please. So if we see the 4 and 5 means the patient and the beneficiaries, they are getting substantial benefit. So that denotes that the overall benefit, the money spent for the treatment part is really beneficial as compared to the other counterparts. So this is very relevant to our country also, that whatever money we are paying, are we getting substantial difference in the quality of life, PFS or OS? Next, please. So, from the indolent or from the slow going to the rapidly or aggressive disease. So, Dr. Sandeep, how do you see your patients who are in like going from the aggressive phase?
So, in upfront setting, a reasonable percentage of patient can present with visceral crisis, organ dysfunction, with jaundice, particularly with the liver involvement. So, however, if still in these patients, if the organ function is not impending, a reasonable proportion of these patients can be managed with the ribosiclib based endocrine therapy.
So, Dr. Hemant, you also agree, and like what is your threshold to start chemotherapy in these patients?
Yeah, impending visceral crisis, extensive metastatic liver failure, or pulmonary compromises are there. More than 3 metastatic sites involving brain, lung, liver. In that patients or dyspnea is there, I will try to start chemotherapy. Otherwise, these are the only few patients will be there. Otherwise, I will give the CDK4 inhibitors plus an AI.
Right. Next slide, please. So, in fact, initially, next, please. So, if these patients with high disease burden or clinically aggressive, Dr. Rohit, what do you tell the patient? Because there is like a conflict patient always feels, and we all are tempted to start the chemotherapy upfront. So, how do you counsel the patient when they come to you with high disease burden or they feel sabab to chemo de do?
So if the patient is upfront high disease burden, aggressive disease, and if there is imminent any organ failure risk, then still my obligation is towards CDK4/6 and AI only. Though I give the option to the patient that CDK4/6 with AI are almost equivalently effective as compared to chemotherapy, as per the right choice study. And I'll go for the chemotherapy only if there is a primary endocrine resistance, if the patient progresses on CD46 inhibitor or AI.
Very right. So in fact, I also call them that within like 3, 4 days or after say within 1 week, I usually call them with repeat LFT or repeat like the whatever abnormality might be, some hypoxia, some cough or other things. So most of them, in fact, but like if you call them within 1 week or after 1 week, so we are able to catch them that how one is responding. And in fact, sometimes we see dramatic response, the liver shrinking and the SGOT-PT getting normalized within very short period of time. Next slide, please. So this right choice study already Dr. Rohit has had something that as compared to chemotherapy, the response is much better and the main driver is the endocrine. So the efficacy of chemotherapy is less as compared to the other part. Next, please. This also we have discussed that the median PFS is almost double as compared to chemotherapy alone. So always we like are tempted towards use of the endocrine-based therapy rather than the chemotherapy. And the whole goal is to push the chemotherapy towards the end. Next, please. So this we have discussed. Next, please. Anything related to Asia impact in the next, please. We will see some subset from the Asian patients. So in this, like the Asian Govind Babu sir was the author of this paper and the contribution from India. Next, please. And they have documented that the Indian patients also do equally good, and there is no significant difference in the Asian versus non-Asian. Next, please. Next, please. So we can see the 3 month and the later on also the time to treatment failure also is better with the ribociclib as compared to the combination chemo. Next, please. So these are real world data. These all side effects we have done. Next, please. So these are the guideline statement, and these results suggest that the ET plus CDK4/6 inhibitor is standard of first line treatment of majority of the patients who are HR positive. Even patients who are clinically aggressive disease, this sounds better as compared to the chemo alone. Next, please. So given the one of the co-authors, if you are the one of the co-authors of these guidelines, what is your perspective on application of these guidelines in clinical practice? Rohit has already said that in first line he is using the CDK4/6 inhibitor. Sandeep, you also agree or you have some reservations?
No, sir, agreed, sir.
So I think we all agree, and now we all are practicing this only. Next, please. So we have 3, 4, I think, more minutes. Organizers, please let us know if we are overshooting the time. So this remains important, Dr. Rohit. If someone has progressed on CDK4/6 inhibitor, what do you do next?
So next we'll go for ESR1, PIK3CA, AKT, and P10 mutation pathway. If it is mutated, then we will go for ESR1 directed therapy, Lasostrant, CDK4/6, fulvestrant, and capivasertib. If both are wild, all the pathways are wild, then we can again go with another CDK4/6 inhibitor with another hormone therapy. Like if Pelbo was used, then we can go for with ribociclib or abemaciclib. Ribo was used, then we can go with abemaciclib and another backbone of hormonal therapy. If
Sandeep,
AI was
you
used,
do
then we
the
can
same.
go with fulvestrant.
Sandeep, you also do the same. You change the CDK4/6 inhibitor.
So post palbociclib, I can use ribociclib or abemaciclib, but post ribociclib, the data is not in favor of users of abemaciclib or palbociclib.
I think that is very, very right that the data favor that if you use Pelbo, then probably we can switch over. But if someone is exposed, there are some data about the Amoeba to Ribo, but Ribo to Ribo again, it's doubtful that how the effect will be. Dr. Hemant, there was a trial of maintain trial. Next slide, please. So these are different trials. So in the maintain trial, again, patients who have been exposed to prior Pelbo in the Ribo, they were continued with ribociclib, and there was some benefit in this. Next, please. So this was maintained trial that ribociclib significantly reduced the risk of progression or death in almost 43% patients who had progression on CDK4/6 inhibitor. Can anyone check? Are we overshooting that? It was for 750 or we can continue? Dr. Sachin?
Sir, you can continue for 2 to 3 minutes more, sir.
Okay, great. Then. Thank you so much. Next slide, please. So this is again important how you switch from the amoeba to the ribocyclic. Next slide. So does the choosing ribocyclic make life easier for our patient? Dr. Sandeep, let me start from you.
Yes, absolutely. It's very much patient friendly in terms of efficacy and in terms of toxicity.
So it works in both low burden as well as the high burden disease. Right. Dr. Hemant, how do you explain about the survival data to the patient if someone comes with uh, metastatic disease with HR positive?
Yeah,
When we start.
basically, ribociclib is in hormone resistant as well as hormone sensitive, and it is showing overall survival benefit in both subsets. So those patients who have progressed uh, earlier than less than 12 months of starting hormonal therapy, in that one ribociclib is also doing good. So as well as his tolerability is also good, and those who have a bone marrow depression in that one we can also give, but definitely we have to do ECG and cardiac monitoring for these patients. Otherwise, drug is well tolerated, and survival benefit our palbociclib as well as abemaciclib is there.
Dr. Rohit, same or you want to add some other points?
Agreed with sir. And concerning neutropenia, definitely every 21 days if we go for CBC, then we can find neutropenia of around 2,800 TLC to 2,800 to 3,000, where one or two single filgrastim doses are sufficient to start again the next cycle. So I think easily manageable drug, easily tolerated, and survival data is also robust.
Great. Next slide, please. So I think with this, we come to the end of today's panel discussion. On behalf of Dr. Rohit Swami, Dr. Hemant Dadi, and Dr. Sandeep, we all are thankful to Dr. Sachin and his team for giving us an opportunity. And once again, we thank Novartis for getting the help from the Novartis brand, in fact, on this Crixana. With this, we end up this panel discussion. Thank you so much, and back to you, Dr. Sachin and team.
Thank you, Lalit sir. Thank you very much for very nicely you have done this moderation and giving insight in the CDK4/6 inhibitor as we can use it as a first line, and how this CDK4/6 inhibitor uh, uh, manage a better life of the patients, and how we can also, even on the progression, we can shift to the other CDK4/6 inhibitor. And thank you all the panelists for your very well inputs and nice presentations of all the questions. And this is very wonderful. Thank you again, all the panelists and Lalit sir. Thank you very much. Now we will go to the next the session, which is sponsored by the AstraZeneca. And this is the trastuzumab deruxtecan for the treatment of HR positive with low and ultra low in case of metastatic breast cancer. And this will be presented by the Dr. Neha Rao from Jaipur. Dr. Neha, over to you.
Thank you, sir. Hello.
Okay, ma'am, you are audible. Please make it full screen.
Yes. Is it visible?
Yes, ma'am, screen is visible. Please make it full screen.
Now, okay?
It's okay, ma'am, now.
Okay. Thank you, AstraZeneca and Sachin sir, for the opportunity. So today's talk is on TDXD for the treatment of HR positive and HER2 low or HR positive HER2 ultra low metastatic breast cancer. So overview of the talk is introduction, the unmet need in HR positive and HER2 negative metastatic breast cancer, and HER2 mechanism of action, and Destiny's Breast 06 study design, efficacy, safety, and health related quality of life data, and adverse events effects management guidelines, and then summary and guideline recommendations. So I'm starting with introduction and background. So the majority of HR positive HER2 negative metastatic breast cancer express clinically meaningful levels of HER2. So if we see the spectrum of HER2 negative disease, it can be HER2 low, that is ISC 1 plus or ISC 2 plus with ISH negative 60 to 65%, and HER2 ultra low, that is ISC 0 with membrane staining only, and ISC 0 with absent membrane staining. So low and ultra low are the HER2 expressing diseases. So Destiny Breast 06 targets this low and ultra low HER2 expressing tumors in metastatic breast cancer. So like ISC 2 plus and ISH negative, that is weak to moderate and complete membrane staining, more than 10% of tumor cells, and ISC 1 plus, that is faint incomplete membrane staining in more than 10% of tumor cells, that is ISC 1 plus, and in ISC 0 also with faint and incomplete membrane staining in less than 10% of tumor cells, this is HER2 ultra low disease. So all three categories are included in the Destiny Breast 06 trial. So the unmet need in HER2 HR positive, HER2 negative metastatic breast cancer. So if we can see the current treatment landscape and outcome like median PFS. So in first line we use endocrine therapy with CDK4/6 inhibitor. So the median PFS is 24 to 28 months if CDK4/6 inhibitors is not used prior. And in second line, if we use endocrine therapy with targeted therapy and prior CDK4/6 inhibitor is used, then median PFS is 5.5 months. And with endocrine therapy alone, it is 1.9 to 2.6 months. In third line setting, if we use single agent chemotherapy, in metastatic breast cancer, which are mostly chemotherapy naive, then the median PFS is 6.2 to 7.1 month. And if we use TDXD in HER2 low disease, that median PFS is 10.1 month. And if we see if we give first line therapy, then we give second line therapy, then we give third line therapy, then the discontinuation rate is around 17 to 18% with each line of therapy. So there is a need for more efficacious therapies earlier in the treatment pathway. So the TDXD mechanism of action, like it is a ADC, antibody drug conjugate. It has an antibody which is which is linked with a highly potent topoisomerase 1 inhibitor, that is a payload, that is a chemotherapeutic agent. It is linked with a tetrapeptide based cleavable linkage. So the and one molecule of antibody contains 8 molecules of the chemotherapeutic drug. So the drug to antibody ratio is 8:1. So the HER2 is expressed on the tumor cell, and this HER2 is binds with the TDXD, and then the drug gets the internalized. Then the linker is cleaved, and topoisomerase 1 inhibitor, that is the chemotherapeutic agent, is released, and they kill the tumor cells and also nearby the neighboring tumor cells also. So thus they result in bystander anti-tumor effect. So this is the mechanism of action of TDXD. So in Destiny Breast 06, the study design is it is a open label randomized multicentric phase 3 study. The patient population which it has included is HER2 positive, HR positive metastatic breast cancer with HER2 low, that is ISC 1 plus or ISC 2 plus with ISH negative, or HER2 ultra low, that is ISC 0 with membrane staining, and chemotherapy naive in metastatic breast cancer setting. So prior lines of therapy allowed are 2 or more than 2 line of endocrine therapy plus minus targeted therapy for metastatic breast cancer, or one line for metastatic breast cancer, and progression in less than 6 months of starting of endocrine therapy plus CDK4/6 inhibitor, or recurrence within 24 months of starting of adjuvant endocrine therapy. So 1:1 randomization done, and TDXD was given as 5.4 mg per kg Q3 weekly. And the other arm is treatment with physician's choice, like they give capecitabine, nab-paclitaxel, or paclitaxel. So the primary endpoint was progression-free survival, that is blinded independent central review in HER2 low disease. Secondary and the key secondaries are PFS in intent to treat population, that is low and ultra low disease, overall survival in HER2 low, and overall survival in intent to treat population. So the population is stratified on the basis of prior use of CDK4/6 inhibitor, HER2 expression, and prior use of taxane in the non-metastatic setting. So the demographic and key baseline characteristic are like sex, race, region, ECOG performance status. So all these baseline characteristics are comparable in all the arms. Others like HER2 expression, that is divided in HER2 low, ultra low, ERPR status, primary endocrine resistant stage 4 disease at diagnosis, bone only disease, visceral disease, liver mets, brain mets, and number of metastatic sites. So all these are comparable in both the arms. Previous lines of endocrine therapies, number of lines, and previous therapy used. So all these are comparable in HER2 low, intent to treat, and HER2 ultra low in both the arms. So the Destiny Breast 06 efficacy, safety, and health related quality of life data was like the first is PFS. If we see the PFS in HER2 low disease, that is the primary endpoint of the trial, the median PFS in TDXD arm was 13.2 months, versus in chemotherapy arm it was 8.1 month. The difference is 5.1 month, and hazard ratio is 0.62. So TDXD demonstrated a statistically significant and clinically meaningful improvement in PFS compared with standard of care chemotherapy in HER2 low disease. Then PFS is in intent to treat population, that is HER2 low and ultra low both population. That is a secondary endpoint. The TDXD again demonstrated a statistically significant and clinically meaningful improvement in PFS compared to standard care of chemotherapy. The hazard ratio is 0.64. The overall survival in HER2 low and intent to treat population, like 12-month overall survival in TDXD arm is 87.6 month versus 81.7 month in chemotherapy arm. And in intent to treat population, the 12-month overall survival is 87% in TDXD arm and 81.1% in that chemotherapy arm. So 20.1% of patient in chemotherapy group received TDXD post-treatment discontinuation, that is in HER2 low disease, and 17.9% of patient in chemotherapy group received TDXD post-treatment discontinuation in intent to treat population. So TDXD demonstrated a consistent median PFS benefit across pre-specified exploratory subgroups, like in all age groups, HER2 expression, whether it is ISC 1+ or 2+ with ISH negative, previous CDK4 use, or with or without the use of CDK4/6 inhibitors, previous taxane use, number of endocrine therapy use in metastatic disease, whether it is primary endocrine resistant or secondary endocrine resistance, and previously used chemotherapies, and whether it is liver mets or without liver mets. All these subgroups favors, in all these subgroups, TDXD favors in PFS and OS in HER2 ultra low. That is like in if we see the PFS, the TDXD shown median PFS 13.2 month versus in chemotherapy it is 8.3 month. The benefit is 4.9 month, and hazard ratio is 0.78. And in if we see overall survival, the 12-month overall survival rate in TDXD arm is 84%, whereas in chemotherapy arm it is 78.7% in ultra low disease. So PFS improvement with TDXD versus chemotherapy in HER2 ultra low disease was consistent with results of HER2 low disease. So Destiny, if we see Destiny Breast 06 overall response rate and breast overall response based on BICR, the confirmed that is the complete response in TDXD arm with HER2 low disease in 9 patients, and no complete response in chemotherapy arm in intent to treat population, complete response in 13 patient, and no one in chemotherapy, and HER2 ultra low, it is in 4 patient, and no one in chemotherapy. Likewise, the partial response is also better in TDXD arm in all the in all HER2 low, ultra low, and intent to treat population, and stable disease is more in chemotherapy arm. So TDXD demonstrated a significantly higher response than chemotherapy, with over half responding versus one third with chemotherapy, and showed uniform efficacy across HER2 low and HER2 ultra low population. So PFS by time to progression on first line endocrine therapy plus CDK4/6 inhibitor and endocrine resistance. So if it is first line time to progression is less than 6 months, the hazard ratio is 0.38. The median PFS with TDXD is 14 months, 6 to 12 months first line time to progression. Then TDXD median PFS is 13.2 months, hazard ratio is 0.69. If more than 12 months, then also hazard ratio is 0.67. So if it is primary endocrine resistance or secondary endocrine resistance, hazard ratio favors the TDXD use. So TDXD improved PFS versus TPC regardless of time to progression on first line endocrine therapy plus CDK4/6 inhibitor or type of endocrine resistance. So PFS2, that is investigator assessed PFS in overall population, overall intent to treat population, and time to progression subgroups. So in intent to treat population, the TDXD investigator assessed median PFS is 20.3 months versus in chemotherapy arm, it is 14.7 months. The benefit is 5.6 months and hazard ratio 0.62. So if the time to progression is less than 6 months, the hazard ratio is 0.73. 6 to 12 months, then it is 0.59. And if it is more than 12 months, then also it is 0.57. So delay in PFS2 was clinically meaningful in favor of TDXD in intent to treat population and time to progression subgroups. So PFS my measures of disease burden. If on the baseline, if disease is like less than 3 sites or local or metastatic sites, then also then hazard ratio is 0.55. The median PFS with TDXD is 15.3 months, and if it is more than or equal to 3 local or metastatic sites, then hazard ratio is also 0.71. So PFS benefit was TDXD was observed regardless of disease burden, with notable efficacy in patient with lower disease burden. And if we see the whether it is liver metastatic disease or not, baseline tumor size, and the patient is in visceral crisis or not, all these subgroups favors the TDXD group. So the safety of safety analysis, then the overall safety, the any treatment emergent adverse events more than grade 3 or more than grade 3 is 52%, 52.8% in TDXD arm, whereas 44.4% in chemotherapy arm. The most common treatment emergent adverse event associated with the treatment discontinuation was TDXD. In TDXD was pneumonitis, that is 5.3%, and in chemotherapy arm it is 1.4%, with peripheral sensory neuropathy. And most common adverse event associated with dose reduction is nausea in TDXD, that is 4.4%, in and PP that is hand-foot syndrome or palmar plantar erythrodysplasia is 16.7% in chemotherapy arm. So the treatment the adverse event with treatment discontinuation is 14.3% in TDXD arm, 9.4% in chemotherapy arm. Dose interruptions are 48% in TDXD arm and 38% in chemotherapy arm. And dose reductions are 24% in TDXD arm, whereas 38.6% in chemotherapy arm. So exposure adjusted incidence rate of treatment related treatment emergent adverse events, if we see this rate for grade 3 treatment related adverse events for this patient 0.4 per year in TDXD arm and 0.5 per year for chemotherapy arm. The safety profile, the most common, the side effects associated with TDXD is nausea, fatigue, alopecia, neutropenia, anemia, transaminase increased, vomiting, diarrhea, leukopenia, and Hand-Foot syndrome. So nausea is the grade 3, but grade 3 or more than grade 3 are 1.6%. In TDXD arm, whereas 0.2% in chemotherapy arm, it is for nausea. So neutropenia 20% in TDXD arm. So special interest adverse events for TDXD, it is like adjudicated as a drug-related ILD or pneumonitis. That is median time to onset of ILD and pneumonitis in TDXD arm was 141 days. The range is 37 to 835 days, and grade 3 event is in 3 patient like 0.7%. And in if we see left ventricular dysfunction, grade 3 is again in 3, and in for cardiac failure, no one in TDXD arm. So of 49 total 49 patients in TDXD arm experienced the pneumonitis. So of 49 patients of any grade ILD or pneumonitis in TDXD arm, 20 were reported as having recovered. In chemotherapy group, ILD or pneumonitis occurred in 1 patient. This was grade 2 event, and that resolved after the treatment discontinuation. So quality of life, if we see quality of life, the TDXD maintained overall health related quality of life and functioning versus chemotherapy in patient with HR positive and HER2 low and HER2 ultra low metastatic breast cancer. So despite treatment with NHER2 being 2 times longer versus chemotherapy, and HER2 maintained overall health related quality of life to a similar extent as chemotherapy in patient with HR positive and HER2 low and ultra low metastatic breast cancer. Gastrointestinal symptoms, including nausea, vomiting, were not detrimental to quality of life in HER2 arm. So conclusion of Destiny Breast 06, the TDXD demonstrated a statistically significant and clinically meaningful PFS benefit versus TPC, like that is conventional chemotherapy in HR positive, HER2 low metastatic breast cancer in an earlier line of treatment than Destiny Breast 06. Results in HER2 ultra low were consistent with HER2 low disease, and confirmed overall response rate was 57% in TDXD arm versus 31.2% in TPC in intent to treat population. New safety signals were identified. Interstitial lung disease remains an important safety for TDXD. So Destiny Breast 06 establishes TDXD as an effective new treatment option for patients with HR positive, HER2 low and HER2 ultra low metastatic breast cancer following one or more than one endocrine based therapy. So PFS we have seen previously. So
Sorry to interrupt you, ma'am. We are running short of time. Please conclude your talk in next 2 minutes.
So for nausea, that is the most common side effect. The guideline to incorporate on day 1 5-HT3 antagonist with NTK receptor antagonist and dexamethasone. The real world data supports the 3-drug regime. And for symptom identification and investigation of first sign of ILD pneumonitis, the sign of symptom is cough, dyspnea, fever, and worsening of respiratory system. So we need to be aware for the symptoms and guideline of management. So guidelines for management of these in grade 1, we have to interrupt HER2, and if it resolves in 28 days, we can maintain the dose. In grade 2 and grade 3, we have to permanently discontinue the NHER2, and in grade 1, we have to give the steroids, systemic steroids, and followed by gradual tapering. And grade 2 also, we have to start with steroids, and in grade 3, it needs hospitalization. For drug-related ILD, the monitoring should be on regular basis, like lung examination, respiratory function testing, oxygen saturation, and HRCT. So multidisciplinary team involvement is must in for the adverse events management, and the guideline also incorporate this. The TDXD outperformed the chemotherapy when used for post two line of endocrine therapy and demonstrated favorable benefit risk profile. So the ESMO 2025 guideline incorporated this TDXD use, and NCCN also incorporated the use of TDXD in HER2 low and ultra low disease. Thank you.
Thank you, Dr. Neha, for very fine presentation on the role of TDXD in low and ultra low HER2 positivity. Previously, we have no option in this low and ultra low, and after coming of this TDXD, there is a new option for these patients. So thank you very much for nice presentation.
Thank you, sir.
And now we will switch over to our next panel discussion, that is management of metastatic triple negative breast cancer. And this session will be moderated by Dr. Divesh Goyal. And the panelists are Dr. Manoj, Dr. Ankit, Dr. Umesh, and Dr. Pramod. So over to Dr. Divesh. Divesh, please start your talk.
Thank you, Sachin sir, and thanks for giving this opportunity. And I think yesterday I was finalized as a moderator. So before this, I am a part of this panel discussion. So thank you, Dr. Sachin Bhai, for this opportunity. So definitely we will discuss on this topic of this TNBC. So I think my panelist is Dr. Manoj Mahajan. I think he is there. Dr. Ankit Nehra, Dr. Umesh Bhai, Dr. Pramod Pal, and Sachin Bhai.
I think Devesh, Dr. Umesh is joining, and Dr. Pramod Pal is not picking the call.
Yeah.
So,
Dr. Umesh sir is here.
Okay. So we all three, I think, including me.
so this is a panel discussion plus this is a topic presentation. I think by Devesh, so we can proceed, Devesh.
So I think we can discuss with you and me, and we will discuss on the final aspect. So,
Yeah.
so definitely we all know that the TNBC is very aggressive in this breast cancer. And we all know that there is survival is very less, and there is early chances of recurrence. Even after adjuvant completion of adjuvant treatment, there is early recurrences, and after recurrences, the metastasis, and there is very fewer options in the metastatic setting. So we know that this is the very aggressive disease, and now we are focusing on this the genetic B BRCA related therapies as well as the PDL1 based immunotherapy. So I think two drugs in our basket to improve overall survival. And immunotherapy nowadays we are using in this neoadjuvant setting, even the clinically T1C disease. So Sachin Bhai, what is your opinion? So definitely we all know that since we are in DM time in doing DM, so there is very limited or fewer options, carbopacly and carbozem. So I think over a times in last 10 to 15 years, what is your experience in this TNBC journey?
I think that the journey of TNBC is very dramatic. Like there are chances of early recurrence, and after 3 years of remission period, the chances of then recurrence are less. So there is paradigm in the TNBC, and as you know, as you told me previously, only chemotherapy like this is the Paclitaxel carbogem is available. After that, eribulin also came into the action, and nowadays the TNBC also the germline mutations like BRCA1, BRCA2 are more common. So there are also other options like olaparib, and we are also doing in TNBC like TMB, MSI, PDL, and so immunotherapy is also available nowadays for TNBC.
So definitely we are treating initially with this T1 or T2 disease. Initially surgery is followed by the adjuvant protocols. We are using the dose dense protocol. So AC followed by paclitaxel. And if the disease is N1 or N2 or N3 node positive or T3 more, we are giving the adjuvant RT. So beyond this, the journey of this addition of platin. So what do you think about the addition of platin in this TNBC? In which setting you prefer addition of this carboplatin to this paclitaxel, even in neoadjuvant setting or even in adjuvant setting? So which patients do you prefer to add this platin?
Ideally, those patients who are germline mutation positive like BRCA1 and BRCA2, initially it was only for these patients. The benefit was seen only in these patients. Either in the even we are using in the neoadjuvant in the chemotherapy along with Pacli, and even in the when we are giving adjuvant, then we are also using carboplatin in TNBC patients.
So can we add the platin in even we don't know the BRCA1 mutation status. So can we add the platin to high risk subset of these patients?
Yeah, exactly. We can use this carboplatin even the TNBC in the high risk like not positive disease and even Ki67 is high, then we can use carboplatin in these patients.
So definitely, the I think the first the AC or paclitaxel. So I think the next journey is the addition of the splitin.
Okay.
In the even neoadjuvant protocols or even in this adjuvant protocol. So beyond this, I think the addition of this splitin, and beyond this, we are doing the BRCA1 as well as BRCA2 mutation in each and every subgroups. And suppose comes to be positive, so we are offering the olaparib in this adjuvant settings after completion of neoadjuvant treatment as well as surgery as well as, and we are depending on the situations the pathological CR is achieved or not. So next we come to this the immunotherapy options. So I think we will discuss one by one. So we all know that we will cover the main two topics, early TNBC. So the trial is Keynote 522 and the metastatic setting. So we know that advanced TNBC setting. So in this, we discuss about this Ascent 04 trial. So we will discuss both these trials. We all know that the study design is, this is the Keynote 522, the multi-center, double-blinded, placebo-controlled and randomized phase 3 trial. So we all know that in this newly diagnosed clinically T1C and 1 to 2 or T2 to 4, or in this categories N0 to 2, TNBC aged 18 or more than 18 years, PS is 0 to 1, and tissue sample is nowadays available for PDL1 testing. So all these subsets were included, and we are starting with this neoadjuvant phase. So in this, the 12 weeks, so carboplatin plus paclitaxel we can give in every 3 weeks versus weekly schedules, and pembrolizumab every 3 weeks 200 milligram were added. Following completion of these 4 cycles, we are adding this AC, so doxorubicin or epirubicin plus cyclophosphamide, versus without this immunotherapy, this pembrolizumab. And following this, the patients are going to this surgery, and following this, after this surgery, so pathological CR were achieved or not. So adjuvant phase, though, so they said that complete further 9 cycle of pembrolizumab 200 milligram every 3 weeks versus placebo. So the primary endpoint for this trial is the pathological CR YPT0 by the local reviews and event-free survival by the investigator. And the key secondary endpoint still the same with OS, EFS, as well as the quality of life and safety. So, so what do you think? So, would you offer this Keynote 522 for a patient with clinically T1C primary as well as clinically node negative axilla? And what do you think that choice of chemotherapy one? So we will discuss one by one. So do you think that suppose the one patient comes in your OPD and the patient is affordable? So can we use, are you comfortable to using this pembrolizumab along with this chemotherapy arm? So based on this trial.
Yeah, based on this trial, we can use the pembrolizumab in triple negative breast cancer, even with the not negative axilla. Because it recently came into the action, and or some guys has used this pembrolizumab along with the chemotherapy in TNBC patients, even I think T1C patients. But practically, I have not used this pembrolizumab in these kind of patients.
So definitely, my experience is still the using this the pembrolizumab T2, T3, or even node positive patients. I have used pembrolizumab, but I have not used this in this category of patient. But nowadays, the NCCN guidelines as well as the supporting guidelines are recommending that we can offer the regimes to these of patients. And back, I think we all know that the choice of chemotherapy is backbone is along with this carbopacly, as well as we know the with the AC. So the recent St. Gallen's or Vienna 2025 summary of this key message on this therapy in early breast cancer. So they shared that in a live voting, only 46.3% would initiate a pembrolizumab regimes in a patient with clinically node negative axilla and a tumor measuring 1.75 centimeter on ultrasound. So still the choice of clinician is almost 50%. 50% are not offering in this subset and 50% are offering. So the next is, so the discussing the optimal neoadjuvant pembrolizumab based chemotherapy scheduled in stage 2 node positive TNBC. The majority voted for with this weekly paclitaxel compared to the weekly carboplatin followed by the 3 weekly AC. So I think, Dr. Sachin, you are comfortable 3 weekly schedule versus weekly schedule in the backbone of this pembrolizumab, even the neoadjuvant protocol. So you are comfortable with this weekly paclitaxel or carboplatin versus 3 weekly.
If we discuss about the comfort of the patient, then if patient is coming every 3 weekly, then patient is better. But when we discuss about the overall survival, as we already know, the weekly pacli is better than 2 weekly and better than 3 weekly. So then in that condition, the dose is not going too high in weekly. So patient is comfortable from the side effects point of view. So I'm comfortable with the both the regime, but we prefer the weekly paclitaxel and carboplatin in these patients of the TNBC.
So definitely in my personal view and as well as weekly paclitaxel is more comfortable. Even I think the we are using the 80 milligram per meter square. So I think compared to the dosing of 175 milligram per meter square every 3 weekly, dose can be delivered within 3 weeks 80 milligram, the 240 milligram per meter square. So I think dose can be delivered more in a better manner, compliance is better and lesser side effects. So I think in paclitaxel, which side effect you encounter in 3 weeks? So I think in my practice, the patient is suffering from severe pain
Exactly.
on first 7 to 10 days. Then the pain intensity is reduced. So I think the main side effect is neuropathic pain as well as the pain. So I think weekly paclitaxel can avoid these side effects more effective manners. As well as I think dose can be delivered and timely, the dose can be completed within the 12 weeks. So I think the weekly schedules can be more appropriate compared to the 3 weekly schedules. So, oh no. So I think if we have given this pembrolizumab based treatment and the PCR was not achieved. So what do you think? So what strategy you favor? If suppose you are using the only chemotherapy regimes without immunotherapy, so what you prefer if the PCR was not achieved? And if suppose if you have used the pembrolizumab, so what do you offer?
Previously, when there is no role of immunotherapy in TNBC, previously we used in these patients adjuvant capecitabine for 6 to 8 months. And after the role of adjuvant pembrolizumab, we can use the patient is affordable the adjuvant pembrolizumab in these TNBC patients.
So I think definitely you are right. So we can offer capecitabine for almost 6 to 8 cycles. So for 6 months we can offer adjuvant capecitabine. I think in my practice 5 to 7 patient is now going on this capecitabine, and in these subsets the CreateX trial. So definitely the role of this adjuvant capecitabine is established if the PCR was not achieved. But definitely if we are using this pembrolizumab, so pembrolizumab can be added along with this capecitabine if PCR was not achieved. So the stage 2 TNBC patient, if with known PCR, so there is the less than 1 centimeter YPN0 after the new adjuvant keynote 5 to 2 regime of 75.8% of panel members would administer this adjuvant pembrolizumab along with this capecitabine. So there is, if definitely pembrolizumab was used in the neoadjuvant setting, so we can combine with along with this capecitabine. So if patient is germline BRCA positive, so what do you think? What do you think? Adjuvant pembrolizumab along with this olaparib, or I think single agent pembrolizumab or single agent olaparib? What is your choice?
Olaparib is essential in these patients. So my first choice is single agent olaparib. And again, if a patient is affordable, then we can use adjuvant pembrolizumab plus olaparib. But exactly, I am not confident of giving pembro plus olaparib in this patient.
So we think that if we have not used pembrolizumab and germline BRCA is positive, so do you offer, if suppose the PCR was not achieved, so do you want to use that along with this capecitabine plus olaparib or yeah, single agent olaparib?
In this patient, I usually prefer single agent olaparib
Okay.
for
Okay.
1 year.
So so what dosing should you start? Initially full dose followed by the tapering if that not tolerated, of yeah, if you are trying the ascending manner.
No, no. I usually start with 150 milligram PD dosing. Then I gradually, after 1 to 2 weeks, I gradually increase it to the 300 milligram morning and then evening. And if patient tolerate, then at the end of 1 month, I give full dose to the patient like 300 milligram PD.
I think in my practice, and my thinking, so we should start with this full dosing upfrontly, and we can the taper off if the patient is not tolerating. And even with this, my experience with this research molecules, the patients tolerate full dose even in this adjuvant ovarian setting, even in adjuvant breast setting. So I think we can start based on the data. We should start along with this full doses followed by the tapering if the side effects or if the grade 3 or 4, so we can reduce the dose accordingly. So definitely the trials also shows that pembro plus olaparib can be added. So the 2025, again the summary in this node positive TNBC patient, the germline BRCA 2 positive or 1 positive, and PCR. So they showed that 4.8% would not recommend adjuvant olaparib. So if they shows that TNBC patient PCR was achieved, even the germline BRCA, so they do not offer this adjuvant olaparib in the 84.8%, but 66.2% of panel members would administer adjuvant pembrolizumab along with this olaparib in similar patient with residual tumors in the lymph node, which although not a standard, is possible in this combination with this according to the initial safety data. So they are saying that if PSCR was achieved, so they are saying that there is no role of olaparib. Just complete this pembrolizumab for no more cycle. And if the guidelines are not saying, suppose the residual tumor are seeing and germline BRCA2 is positive, so they showed that pembro plus olaparib can be given.
Okay.
So I think, would you substitute pembrolizumab with other any checkpoint inhibitor for this indication? Do you think that any other molecules nowadays, atezolizumab or any immunotherapy molecules for this indication?
No, not at present.
Have you any experience? So I think
No.
initially role of atezolizumab was tried in this initial settings. So the trial of this NSABP 59 or GBG 96 Gepard dose study design. So these studies are similar, but in this clinically N1, N2 or N3 or T2 or T3. So in this AT, along with the same schedule carbo with PACLI followed by the surgery and further to complete 1 year of therapy. So the primary endpoint were the EFS and the key secondary endpoint were the OS as well as the PCR in this breast as well as the lymph node. So if we showed that chemotherapy plus placebo were used, so there is 3-year event-free survival were 83.8% versus if we are using immunotherapies 87.7%. So I think 4-year EFS 81.9% in only chemotherapy arm, and with immunotherapy arm is 85.2. So hazard ratio is 0.8 and the p-value is 0.08. So we all know that the PCR rate with this only and only chemotherapy is 57 versus 63.3. So we all know that the median follow-up for the 46.6 months. So the 4-year OS data is along with this chemotherapy is 89.5% versus the chemo plus it is 90.2. So we all know that this study is not so popular. It was tried, but I think data is not so good, and no, either is similar. So I think the Atijo was out in the neoadjuvant settings. So we all know that we discuss the nowadays new. What is the new? So I think addition of this pembrolizumab or olaparib even in neoadjuvant or adjuvant setting is the more common nowadays. So we will discuss in this adjuvant setting. Suppose the patient comes in metastatic settings, the apparently the chemotherapy was completed, radiation was completed, and patient on observation. And patient comes after 6 months with the recurrence even in the lung mets and liver mets. So what do you think that what the next approach investigation and what do you like to how can you treat?
First of all, we should previously Devon, we should assess the receptor status again, and according to that receptor is same even if patient is then TNBC, and if patient is affordable at that time, then we can try to use this pembrolizumab immunotherapy along with chemotherapy, or now along with the SG, as we discussed previously in the first session, the ESCO 2025 guidelines about this T or D19 study.
So definitely we all know that the patient comes recurrence, we do repeat biopsies. That triple negative is well established, and previously BRCA1, BRCA2 was not done, so we are ordering this BRCA1 as well as BRCA2, and we are offering the PDL1 test also to know that the immunotherapy can be given or not along with this chemotherapy schedules. So some patients, I think less than 5% are patients are affordable for this immunotherapy based regime. So we are on the out of this challenge. So we in Indian scenarios, in Udaipur scenarios or Jaipur scenarios or Ayushman or Chiranjeevi scenarios, what do you think? So what do you prefer in the further lines? The treatment line sequences, if you think.
The sequence is if patient DFS is good, then we can again use paclitaxel and carboplatin as the chemotherapy part. And if the patient is already used this and the D5 is less, then we can use carbo plus gem as we are using in our Chiranjeevi patients regularly. So these two options are there. Other are the docetaxel also we can use.
So first, you appropriate.
Dr. Deves, can I make a comment?
Yes, sir. Yes, sir. Yes, sir. Definitely.
So don't say Chiranjeevi or Mai Yojana. You are working in the one of the most premier hospitals of the Rajasthan or Jaipur for that matter. Rather, you are seeing all the patients of this kind and you are treating. So one question is there. I always remain puzzled. In the early stage, let's say typically like stage 2 or 3 node positive patient and TNBC, and when you give the neoadjuvant, let's say chemo plus pembro, typical schema which you have shown here, and patient do not achieve PET-CR, let's say the residual burden is quite high. So I always remain puzzled that for the BRCA positive patient, what should I do? Only pembro plus olaparib, or how to incorporate the capecitabine also in TNBC with the not achieving the PET-CR?
But sir, Abhi, nowadays guidelines in St. Gallen's, the out of the box, they are saying that if the node positive as well as the residual disease, so pembro plus olaparib can be offered. Or I think if pembro are not using, so we can offer with this capecitabine plus olaparib. Hello.
If the patient is fit enough to go for the treatment, do you find any role for capecitabine nowadays?
Sir, I think even the capecitabine can be given, sir.
How to incorporate the all three treatment, or at the most only the two can be incorporated?
Sir, I think two. I think pembro plus ola. Cap I will not give. In that scenario, if germline BRCA is positive.
Thank you.
So in that scenario, so the next drug, what other drugs, eribulin hai, as well as the capecitabine. So what do you think about all these drugs in the metastatic settings?
Yeah, the TNBC is very difficult to treat in the metastatic setting. So sequentially, we can use these medicines like first paclitaxel, then gemcitabine based treatment, then eribulin, and then these are the capecitabine. The sequence is, I think, based on the patient's condition and residual disease.
I think, can you offer the eribulin in the first line or second line in TNBC? What do you think?
Ideally, we should use in the first line, the eribulin, then the response is good. When we are using it in the second, third, or further lines, the response rate is very less.
Okay. So suppose the patient is maintaining the stable disease or partial response. So do you shift some maintenance regimes after the chemotherapy?
Yeah, if we have used complete cycles of the injectable chemotherapy, then we have options of in the continuation we can give this capecitabine tablet for long time.
Do you initially use the FSC regimes, even triple negative patients after carbopacly and as well as other regimes, the disease have progressed. So you have rechallenged if the doses remain. So do you have
No, I have
rechallenged the
not.
FSC or AC?
I generally not use adriamycin or epinephrine again in these patients. Better than we use the taxane-based treatment.
Okay, fine. So in the advanced settings in this era, so this is the Ascent 4 trial. So this is the global multi-center randomized phase 3 trial. So in this previously untreated, locally advanced, unresectable or metastatic TNBC, there is PDL1 positive and 6 or more than 6 months since curative treatment. So in this, the secukinumab govitecan plus pembrolizumab versus the chemo plus pembrolizumab. So in this treatment until continued. So there is until the progression or unacceptable toxicity. So the primary endpoint were the PFS as well as secondary endpoint were the OS and overall response rate and duration of response, safety as well as the quality of life. So the data is also well balanced. We all know. So the trial showed that this SG plus Pembro in this median PFS are 11.2 months compared to this chemotherapy plus Pembro, there is 7.8 months. So 6 months PFS is 72% versus 63 only chemo plus Pembro, and 12 months PFS is 48 versus 33. So we all know that this molecule's SG is still, it is not available in India. So I think this is the promising molecule in this TNBC settings, even in this advanced metastatic breast cancer settings, we can offer along with this immunotherapy. So this ADC can be combined with this immunotherapy, and definitely in advanced setting, the median PFS are better compared to this along with this chemo plus pembro. So
Sir, sorry to interrupt you. We are running short of time. Please conclude.
I have already just within 1 minute, I am completing. So overall response rate is 60% versus 53%. And the best overall response rate CR is 28 versus 18. And median OS is still not reached. Median duration of response is 16.5 months compared to the 9.2 months. So OS data is still immature and 26% of event is reached. So 81% of patient in chemo plus pembro arm who received subsequent treatment got SG in future. So thank you, Sachin Bhai, and thank you this wonderful topic for this discussion. I think thank you all. Thank you.
Thank you, Devesh, for managing this session very nicely. And thank you very much, Dr. Naresh Somani sir, for giving the insight in this panel discussion. So, in the next, I would like to invite Dr. Naresh Somani sir for the panel discussion, and he will moderate about the management of ovarian cancer. So, over to Naresh Somani sir. Sir, please.
Good evening, everyone.
Good evening, sir.
I don't know how to share my PPT, finding it very difficult. My PPT is visible?
Yes, sir, it's visible, sir.
So is the first slide here, management of advanced ovarian cancer?
Sir, now it's not visible.
No, sir, not visible. Can I present on behalf of you, sir?
Yeah, I think that's better. And the similar problem is that my video is also not working. Host has mutated my video. Anyway, so you can see all the intelligent and the busy practitioner as a panelist here, except me. I'm not visible. So we have with us Dr. Tarachand Gupta, Senior Medical Oncologist from Bhagwan Mahavir Cancer Hospital, Dr. Rohit Swami, consultant from Manipal Hospital, Dr. Ankur Punia from Mahatma Gandhi Medical College Hospital, Jaipur, Dr. Ananya Parikh from Renova Rajasthan Hospital, Jaipur, and Dr. Rahul Rai, Medical Oncologist from Bikaner. So I hope all the panelists are here. Can we go to the next
Dr.
slide?
Rahul Rai and Dr. Ananya is not there, sir.
Okay, so we have the Tarachand, Rohit, and Ankur. Yeah. So my job is easier.
Yes, sir.
And can we go? What I understood from these slides that after the breast and the uterus, cervix cancer, the ovary has surpassed so many other cancer as the third leading incidence wise in the female population. And we all see a lot of ovarian patient, and especially in the elderly population or the age advances. Next slide, please. Next slide, please. Next, please. So let's start with the typical case presentation. Most of the time, the ovarian cancer present at the advanced and where we find that ultimately with all sort of the chemotherapy, sequential treatment, surgery, primary surgery versus debulking, ultimately survival remains the poor. Next slide, please. So a typical case scenario like postmenopausal lady presenting with the lower abdominal pain, vague symptoms of the varied duration, and then finally being investigated, found to have the adnexal mass with the free fluid in the pelvis. And CA125 remains marginally elevated, and these patients usually often go for the laparoscopy, diagnostic laparoscopy, and the removal of the mass as the isolated surgical procedure. Next slide, please. And when the histopathology reported at the adenocarcinoma, then they are moving further for the further referral. So this patient typically has come to Dr. Tarachand Gupta for the further workup. And this patient histopathology reviewed at the Tarachand end as the high-grade serous adenocarcinoma. CT scan further workup was done showing the mild ascites, diaphragmatic or undersurface of the diaphragm deposits, para-aortic nodes as the something like 2 centimeter omental nodules. Chest remains the normal. This is the typical picture. So next slide, please. Next slide, please. So the question comes, what to do now? So Dr. Tarachand, how you decide these patients to immediately go for the surgical evaluation, complete the surgery, or how you assess the patient for the neoadjuvant treatment? What are the criteria in your mind to select a patient who comes after some sort of the laparoscopy or laparotomy, or who comes as the intact patient with this sort of the picture?
Sir, the perfect line from NCCN guideline is the indication of neoadjuvant chemotherapy is that surgeon is not able to R0 resection. In that case, if you think that the surgeon is saying that anesthesia is indicated and primary surgery is not possible for the R0 resection, then take a second opinion from another surgeon. Then you can come to for the neoadjuvant chemotherapy. Still in a practice, we are using like if there is a gross ascites or nodules, those are stick to intestine and where the R0 resection is not feasible actually, high volume bulky disease. And patients are having poor PS, which who may not be perfect for the surgery upfront. We are taking those patients for the neoadjuvant chemotherapy.
Rohit, any point you would like to add, or what is the trick of the practice? How you judge that patient is not suitable for the upfront surgery?
So agreed with Dr. Tarachand, sir. Basically, if the surgeon is not sure that he can go with upfront R0 resection, or if he is going for R0 resection, there is going to be much morbidities of the surgery, then definitely we can go for neoadjuvant therapy, reduce the bulk of disease, and then go for interval cytoreduction surgery. And generally, the patient who had initially underwent laparoscopy and underwent cystectomy, those patients are generally not willing for repeat surgery. So in these cases also in the stage 3C or stage 4 disease, we can go with initial neoadjuvant chemotherapy followed by ICS.
Next slide, please. So there are various randomized trials which are comparing neoadjuvant versus the interval debulking, neoadjuvant chemo followed by interval surgery versus primary debulking surgery. Let's say mild ascites is there. It looks like the disease is operable. Do you still favor the neoadjuvant chemotherapy, Dr. Ankur? Does it make any thought process in your mind that it depends on the infrastructure, whether operable surgeon is the general onco surgeon versus the gynec onco surgeon? Patient looks fit for the primary surgery, and how you decide?
So, sir, what I feel is the biggest thing which impacts the outcome of ovarian cancer is the surgery. How much better the surgeon is, how better the surgery can be done. It's not like a simple TH, BSO, and a mastectomy has been done. So it should be like a proper, cytoreductive surgery. That determines what I will do for that patient. If I know that patient is yes going to get a proper surgery, then I'm happy to send the patient for upfront surgery, because if it's artery resection is possible, I don't care whether patient gets operated upfront or after NACT, so I will send upfront. But where yes, definitely I have a doubt that patient will not get the optimum cytoreductive surgery which needs to be done. Then for such patients, I would prefer to give neoadjuvant therapy. As such, I don't feel there's any much difference. What I feel is that patient should get a R0 resection one way or the other.
So let's say even if the patient seems suitable for the R0 resection, and many times the patient we find out them the inoperable. And the present trials, lot many trials are available which say that in these operable situation, neoadjuvant followed by interval is the non-inferior to the primary surgery. Why you want to subject a patient for the primary surgery?
So it's just an intuition. So the patient might still be, inoperable after neoadjuvant chemotherapy. So we have to take a call one way or the another. So I don't feel personally that there's any difference. That's why I said that it all depends on the expertise of the surgeon. How much expert, how much is going to go for a proper cytoreductive surgery.
Okay. Any point, Dr. Tarachand, you want to add here?
Sir, as you are showing the table, in this table also the upper two are non-inferior NACT, but the rest two are showing that NACT is not achieving the non-inferiority margin. So that's why I think till now the standard or that academic line is that if the R0 is possible upfront, then should go ahead with the R0 resection. If patient is unfit for the R0 resection or unfit for the surgery because of the volume of the disease or their date of surgery and surgery dates are long, then we should consider for the NACT.
Okay, next slide, please. Let's move quickly in the interest of the time. Next, please. So, debulking surgery done, no gross residual disease left behind. Next, please. Next, please. Anything about the HIPEC at this stage? Anybody is fond of recommending the HIPEC as the primary modality of the surgical aspect? Dr. Rohit.
So, sir, if R0 resection is done, is achieved, then HIPEC gives us the survival benefit. So, if surgeon has the expertise in HIPEC, then we should go further.
Okay. Next, please. Next, please. Next, please. So HIPEC has been one of the options given in the guidelines also. Cisplatin plus minus other drugs like the doxorubicin. And it obviously depends on the surgical availability, infrastructure, techniques, and probably at least is increasing the PFS benefit to the patient, if not survival gain, with the attached morbidity with it and the cost and other factors. Next, please. So patient obviously was the high-grade serous adenocarcinoma and making it the advanced stage of the disease, like the stage 3, typical scenario which we often see in this kind of the scenario. Next, please. So now the role for the medical oncologist come. Dr. Ankur, so what you will do for this patient? Blood, BRCA testing, HRD, how you interpret it, and what you do for these data. I always remain confused for the BRCA versus HRD. HRD, BRCA-ness also, HRD scoring also, what to do with the HRD negative, what to do with the BRCA negative. I say no for the PARP inhibitor. Patient goes to Rohit Swami. He says that the rucaparib can be given even if the BRCA is negative. So I will always remain confused. Over to you, Dr. Ankur.
So first of all, ideally for all high grade serious, we have to advise germline, testing. I will advise a broader panel because BRCA1, 2, yes, they are the most commonest, but other genes are also there, which comprise almost 25%. So I will advise a broader, hereditary genetic panel instead of just a BRCA1 or 2. So it should be advised to all the patients for this setting. And secondly, we have, evidence for HRD. So HRD should be sent. So what I will prefer to do is do a germline testing and send a HRD for the patients.
So, Dr. Rohit, when the patient comes first time to you, when do you advise the BRCA testing? After surgery, before surgery, or after completing the adjuvant chemotherapy?
So in the very beginning, sir, in the very beginning, I will go with the germline HRD testing itself. So that even if the patient has completed had the initial R0 resection followed by adjuvant chemotherapy, then I had the knowledge that the patient is going to receive adjuvant PARP inhibitors or not.
Dr.
So
Tarachan, patient has come quickly within 7 days of the diagnosis with the BRCA testing and it turns out with a positive. What you advise for the surgery and what you do for this BRCA positive and counseling for the breast potentiality of the malignancy?
Yes, sir. If this is germline also positive BRCA, then we usually counsel for the adjuvant olaparib in those cases, particularly in stage 3, 4, and also counsel for the offsprings and siblings testing of the germline BRCA1, BRCA2, and particularly mammography and so that breast screening for the same patient also. So usually for the prophylactic mastectomy, I don't know in this era of olaparib is quite useful or not. So as we are offering already olaparib also to the patients over BRCA1, BRCA2. So I'm not sure about the prophylactic mastectomy and etc. But yes, we counsel the patients even at any stage for the testing, germline testing of all the first degree relatives.
Dr. Punia, any input from you on this burning issue?
So, sir, I'll advise the same. I will advise actually the regarding mastectomy, it depends on the age of the patient. What I feel, if patient is post 45, 50, then there is a little benefit of going for a mastectomy. But for a young patient, if patient is willing, then I will advise them to go for mastectomy. Otherwise, a regular 6 monthly screening is advised. As such, we are going to monitor for ovarian cancer.
I do agree because we all know that the ovary patients are going to relapse. Rather, relapse is rather rule rather than exception. So even if they survive 5 years after the adjuvant PARP inhibitor, then we should think of the this mastectomy. Just after 1 or 2 years, I don't think that there is any utility of it. Dr. Roy, do you agree?
agree, sir, agree.
Okay. So let's move to the next point. We will be only covering few of the aspects which are confusing in our clinical practice. Next, please. Next, please. Next, please. Next, please. So we have already discussed the blood-based germline BRCA testing, HRD, and the interpretation of the HRD like HRD-ness, scoring, scar pattern, and the BRCA-ness. I mean, do you find this sort of the report like the BRCA-ness or how you interpret them, and do you take it the solid ground for the PARP inhibitor? Any of you can comment.
So HRD positivity is sort of basically taken like that is like a BRCA ness patient is having what a BRCA mutated patient has. So yes, HRD patients, we have the opportunity to give them the drug, but we have to remember that almost 50% of the patients who have HRD still don't respond to the drug. We have option for the drug, but yes, we have to explain to the patient that it will not work in each and every patient, except for maybe germline patients where the response rates are in the tune of around 70-80%, but not for every HRD, just HRD positive.
Next slide, please. Next slide. So this patient BRCA was negative. HRD, as you people rightly said, that I will send the germline BRCA and I will also send for the HRD test also because that will take some time. Next, please. So adjuvant treatment, lot many options are available. One drug, two drugs, three drugs, four drugs, and then sequential treatment. So in the clinical practice, Dr. Taratun, how you judge the suitability of the patient for the chemo plus bevacizumab, chemo plus beva plus olaparib, or chemo plus olaparib, or even incorporation of the immune therapy based protocol?
Sir, as of now, for the Paula one, there is usually it is used in a patient with a primary cytoreductive surgery. If the disease, residual disease is more than 1 centimeter or pleural effusion upfront. So in that case, bevacizumab comes with the ICON 7 trial. And if it is not the scenario, then usually I don't use bevacizumab in adjuvant setting. Or if I had used bevacizumab in neoadjuvant setting, like it is called at that time that it is looking inoperable, and patient are sent like a very advanced disease, and we gave that as a palliative intent, that paclitaxel and bevacizumab, and but the patient shows a very good response and become operable, then I think I consider adjuvant as a bevacizumab. Regarding
I
olaparib,
would, yeah, please, sorry, I'm sorry.
yes, sir. And regarding olaparib, I give in stage 3-4 cancer patients if patients are BRCA1 or HRD positive, BRCA or HRD positive. For the
One point
durvalumab,
I would
still I have
like
not
to
used.
highlight here that often in the neoadjuvant setting, we don't give the bevacizumab. So bevacizumab works only when the primary surgery is done, followed by adjuvant chemo plus bevacizumab. If you have not incorporated bevacizumab in the induction treatment, then probably adjuvant bevacizumab doesn't work. We need to rely on the olaparib if the BRCA is positive, or maybe rucaparib if you feel that even if the BRCA is negative and you want to give it. Dr. Ankur, do you agree?
Yes, sir, agree. Same.
Rohit, what is your preference in a patient of the part this BRCA positive? How you choose between the two, rucaparib versus olaparib?
So basically, there is more robust data for olaparib in the adjuvant setting. So I'll go with the olaparib alone in these cases.
So you don't have
Though
the pharma.
rucaparib
You
can
do,
be used also, but still, first my preference will be olaparib.
Dr. Ankur?
So I prefer to use olaparib, sir, because of basically because of toxicity. What I've seen is toxicity is much less with olaparib compared to rucaparib, and obviously we have much more data with olaparib. So preference now with the generic is olaparib.
Any of you have seen any incidents of the second malignancy because of the PARP inhibitor?
Sir, experience is not so great. Only I have given only hardly 15-20 patients. So till now, I have not seen any malignancy in ovarian cancer patients and on olaparib. But yes, we encountered anemia so frequently, even using in titrated dose. So hardly in 20 patients, hardly 5-6 patients were able to take full dose of the olaparib. Otherwise, all were or either 3 tablets per day or 2
We
tablets per day.
know that the use has increased over the last 2 years only once the availability of the generic molecules. So maybe the time will come and we'll see it. Can any of you quote any Indian study where the real data of second malignancy incidence is there based on the PARP inhibitor? I am not aware.
Sorry, sir. I am also not aware.
So let's move to the next point. Next slide, please. So we have already discussed this point. Various trials are available, and various points like BRCA positivity, HRD status, cost, toxicity profile, patient preference, and obviously the cost become very important. And once the availability of the one molecule as the generic, I think we always need to give the preference. We need to tell the not only the toxicity, drug interaction, duration of the treatment, outcome. The important factor becomes the cost factor. Next, please. Next, please. Next, please. So various maintenance trials are there, and based on their these mutation in the BRCA versus the HRD versus no HRD. Lot of data are available there. And still, if you prefer that PARP inhibitor need to incorporate it in the first line, even in the BRCA negative patient drugs like the niraparib or the this rucaparib can be offered to the patient, whatever worth they have. Next, please. Next, please. Next, please. Let's move to the next. So patient was put on the olaparib for 2 years, remained asymptomatic, and then after some time, patient developed recurrence and workup was done again. There was a limited disease. So what you will do, Dr. Rohit, after 2 years of the rucaparib, patient otherwise fit, and rucaparib or olaparib for that matter, pelvic recurrence is there, CT scan is done, chest is free, patient is in good general condition. What will be your approach?
So, localized recurrence and patient is PS1 fit and fine, then I'll go for secondary cytoreduction surgery followed by pseudourgent therapy.
So all the other two panelists do agree with that. Every patient should be assessed for the interval, or I mean the second loop surgery.
Yes.
Yes, sir. Desktop 3 is showing that it is possible. The catch point in that trial is that it was no in the GOG trial when there was no benefit of cytoreductive surgery. In that case, bevacizumab was used in those patients. But in the desktop 3, bevacizumab was given only to the 18% of the patients only. So if this is a confounding factor or not, we are not clear. But yes, after 2.5 months, we can offer a cytoreductive surgery to giving the benefit of doubt.
Next, please. So platinum sensitive recurrence, surgery done again, good surgery done. We always keep discussing HIPEC at this stage also. Forget that point. How you will choose the adjuvant treatment? Further adjuvant in platinum sensitive recurrence. Dr. Ankur.
So my preference will again be the same. I will give paclitaxel carboplatin. If patient doesn't have a any residual toxicity like neuropathy or anything, I will again prefer because it's a very long time since the drug has been given. So my first preference will be to give the same drug.
Dr. Rohit, you have always the preference of the Paclitaxel carbo being the sensitive relapse, or you want to incorporate the platinum with some other agent?
No, sir. Paclitaxel and carboplatin are the most effective chemotherapy in the this high-grade serous ovarian carcinomas. And if it is 2 years after 2 years there is recurrence, then definitely paclitaxel will do much better. So I'll go with paclitaxel adjuvant, and if it's HRD positive, then again I'll like to add adjuvant PARP inhibitor.
I think this is the indirectly one of the greater achievement of the maintenance Solapari or bevacizumab for that matter, that they are pushing the patient toward the platinum sensitive recurrence. Anyhow, the
Agreed.
PFS is increasing minimum, obviously the overall survival also. So that increment in the recurrence-free survival is making more patient at the platinum sensitive, and the chances of their sensitive relapse and the response to the second line platinum based treatment is also increasing. Do you agree, Tarachan, with this statement?
Yes, sir. I agree totally that olaparib and these PARP inhibitors have pushed the PFS and making the patients chemo sensitive and prolonging the life.
So let's move to the next point.
Role of
Next point. Next point. So what adjuvant treatment other than the Paclitaxel carbo you have in your mind, or subsequently treatment? It's only the platinum doublet, or you want to incorporate the bevacizumab also? And what about the re-challenge with the PARP inhibitor, typically in a BRCA positive patient? Dr. Rohit.
So rechallenging with the PARP inhibitor in BRCA positive patients had shown PFS benefits, so we can add it after completing adjuvant chemotherapy. Bevacizumab, if used in the neoadjuvant setting, like when there was a localized recurrence, we first gave chemotherapy plus bevacizumab, followed by interval cytoreduction surgery, followed by adjuvant, then bevacizumab maintenance should be continued. And if it is HRD positive, then role in the recurrent setting of maintenance bevacizumab and PARP inhibitors are plus minus, but I will go with bevacizumab and PARP inhibitor maintenance as per the Paola data, extrapolating the benefit to this setting.
Dr. Tarachandra, regarding the re-challenge with the PARP inhibitor, same drug or rucaparib to Ola or olaparib to rucaparib?
Sir, I feel personally that rucaparib is toxic than more toxic than olaparib. So usually I don't prefer rucaparib. And for rechallenging, I have to check that if BRCA1, BRCA2 or HRD status changes at recurrence or not. If it is like same, that the once is positive and permanently it is positive, then I would like to avoid PARP inhibitor. So at this time point, I am not aware that this is true or not, that the BRCA1 status change, BRCA status changes or not with the time. So if it doesn't change, then I will not use. If it changes with the time, then and it is coming again positive on recurrence, so I will feel that we should give again olaparib.
So you commented that the olaparib is more safer or you are able to handle it better way. Are you able to give the 300 milligram BD dose in most of the patients?
Sir, usually, as I told that out of 20 patients, 5, 6 patients were able to maintain the 4 tablets per day. Otherwise, maximum patients are on 3 tablets, and 1, 2 patients or 2, 3 patients, you can say only 2 tablets per day.
So, Dr.
But
Ankur,
rucaparib
do you
causes the
agree with
renal dysfunction in many patients, higher fatigue than olaparib, and it is a difficult drug usually. And I have used in 2, 3 patients, but this was like more toxic than olaparib, I feel.
Dr. Ankur, do you agree with my this comment that as per the literature, olaparib is not effective if its dose reduced to 200 milligram BD? And often I see the prescriptions or the patient preference or our lack of confidence that we sometimes prescribe 150 milligram BD.
So what I feel regarding the dose reduction is that if dose reduction has been done on toxicity, then it is efficacious, then it's remained to be efficacious. But it is if it's just done that if you are afraid of side effects, then I might think it's not that efficacious.
So the literature says that it's a dose reduction to the 2 step down is not effective. Then you have to stop the drug.
Yes, sir.
So 150 milligram, the message which I want to give that dose something loosely being prescribed or accepted, let's say accepted, like 150 milligram BD should be registered, should not be accepted.
It's
Next,
difficult to
please.
say. So if patient is not able to tolerate even 3 drugs, then I will try that 150 BD what Tarachand has said.
Sir,
So,
I think just a quick search showed that BRCA status doesn't change with the time. So it is positive, then positive. If negative, then negative usually.
probably there is no point of retesting it.
Yeah.
So slightly I differ here, sir. What happens because one of the resistance mechanism of PARP inhibitor is there is a reversal of BRCA-NES by some different mutation, which reverses the BRCA-NES. Even the BRCA mutation is there, but some other mutation happens which reverses the BRCA-NES, and those patients become insensitive to PARP inhibitor. This is one of the resistance mechanism that which might happen. That's why I will consider to do a HRD testing again in such
So
patients.
that is about somatic mutation or the germ-like mutation?
Somatic, sir. I'm saying about somatic. Because this patient had a HRD positivity. So
Yeah.
just if germline is not there and HRD is there, even if patient is germline, I will say germline positive, those patients will also eventually might develop some secondary mutation which will
Developing the
reverse their
resistance is
BRCA-NES.
understood, but the germline positivity should not change, if I'm right.
Germline positivity will not change, but secondary mutation will reverse that BRCA-NES of the disease. It will, and the PARP inhibitor will not work in those patients.
That's quite understood. Next slide, please. Next, please. Next, please. Next, please. Yes. So patient obviously is supposed to be there. The patient had the recurrence again. Dr. Rohit, what he will do? The patient has been treated so far beautifully by Dr. Tarachan, but now because the multiple recurrence is there, it's a quite common practice that the patient will go to the second place, and you are obviously one of the names for the second reference. So what you will do now, Dr. Rohit? How you will choose the next line of the treatment?
So still the disease is platinum sensitive, so I will go with platinum as well as lipodox in the second line setting because patient had received 2 times paclicarbo combination. She must be having peripheral neuropathy. So my second line of choice will be lipodox with platinum and with bevacizumab.
So, Dr. Ankur, how long you keep giving platinum?
Till the patient, what I feel is, platinum sensitive, I'll give for 6 cycles, not more than 6 cycles. Then I can either continue maintenance bevacizumab or other drug if it's indicated.
My question is that you have given after the recurrence and the paclitacarbo re-challenge, and after, let's say, after 6 to 12 months, patient has the progression of the disease, quite logical. So how in this scenario you judge the platinum sensitivity? Still you go by the same definition of the 6 months versus more and less, or you feel that it's enough that the twice platinum has been given, first line adjuvant and at the time of the recurrence?
Firstly, we have that definition, but I still feel it's a loose definition. Most preferred thing which I see is how the patient has responded. If patient had a response to previous platinum, then I will re-challenge. If sort of patient didn't have any response, sort of just stable disease to platinum drug, then I will not re-challenge with platinum further.
Dr. Tarachan.
Sir, if the patient is a platinum sensitive at any recurrence, after that, after the first or second recurrence or any recurrence, so definitely I use a platinum along platinum doublet. I don't know what is the OS data and in that situation, but yes, I know that the response rate will be great at that time, and patient will be symptom maybe symptom free or symptom less with less symptom, and that may add a quality of life at that time.
So let's move to the next point. Next point. Next slide, please. So just to conclude, primary treatment, we try to stage the patient, low grade, type of the histopathology, serous carcinoma versus the mucinous. We keep observing few patients without adjuvant chemotherapy. Obviously, the high grade tumor, higher stage of patient, chemo plus maintenance treatment are always there. And we try to incorporate the PARP inhibitor in the treatment and the bevacizumab in the treatment. I think immune checkpoint inhibitors has not been incorporated so far in the clinical practice in the first line. Next slide, please. Next slide, please. Next, please. And recurrent ovarian cancer, yes, it's again multidisciplinary assessment of the various clinical factors like the platinum-free sensitivity, prior treatment, performance status, comorbidity, and the goals of the treatment. And incorporation of the palliative care earliest possible. Standard treatment in platinum resistant remains the newer drug like the mirvetuximab, which is, I think, not available for most of our patients. It's antibody drug conjugate. And for the platinum sensitive, as Dr. Rohit Swami clearly mentioned and supported by the other two, my esteemed colleagues here, that if the platinum-based treatment is the best, plus minus bevacizumab, depending on the feasibility or depending on that what sort of the surgery and the recovery of the patient from the surgery. And yes, try to incorporate the second surgery also. And depending on the BRCA, you try to incorporate the olaparib and niraparib or the rucaparib, whatever available with you. Bevacizumab, yes. And BRCA wild type, probably at this stage, bevacizumab the treatment. Next slide, please. And the most important thing for the ovarian cancer is the multidisciplinary team works. And that is very, very important. Not only the medical oncologist, your surgical colleague, in a few select patients, your radiation oncologist colleague also, especially in the recurrent sensitive, because it's the RT sensitive disease, your pathologist remains very, very incorporate. And when these patients go in the intestinal obstruction, you take the help of your other colleagues like the critical care, palliative care. And obviously, the gynec onco surgeon is very, very important. We often keep talking, at least making the comment that the 6 months difference in the survival is there if the proper surgery in the proper hands are done. So multidisciplinary team, ovarian cancer is the best example of that. And once again, greetings to all of you. Thanks for this opportunity. And especially greetings from my center, SCG Cancer Center. Over to organizing team. Thanks to Dr. Sachin Jain also. And thanks to my three panelists present here. Thank you.
Thank you, sir. Good
Thank
evening.
you, sir.
Thank you very much, Naresh sir, for very wonderful moderation of the role of how we treat ovarian cancer in 2025. And I would also thank you, our whole panelists, for their active participation. Thank you very much.
Thank you everyone for joining us today. Good night, technical team.